Hey everyone, welcome to the video from Module 5.3. In this one, we're going to discuss articulations, better known as joints. Again, these are the learning outcomes and the objectives that I want you to focus on while you're taking the quiz and focusing on the unit exam. So, articulations and joints. This is essentially the place of movements where two or more bones meet. And because the bones of the skeleton are relatively inflexible, movement can occur only at articulations or joints where these two bones interconnect. Each joint reflects a compromise between the need for strength and the need for mobility. As a result, articulations differ in the amount of movement permitted, and this property is also known as range of motion. And the anatomical structure of a joint determines the type and amount of movement that may occur. Articulations are often categorized by a range of motion and anatomical structure. Articulations can be classified as structural classifications that are based on the anatomical components that make up the joint. You have fibrous joints, which are held together by fibrous connective tissues but lack cartilage and possess no cavity between the bones. Fibrous joints are either synarthrotic or amphiarthrotic, and we'll get to those in just a moment. You can have cartilaginous joints, and these are held together by fibrous connective tissues such as ligaments, but they also possess either hyaline cartilage or fibrocartilage. Cartilaginous joints lack a joint cavity and are either synarthrotic or amphiarthrotic. And then synovial joints. And these are held together by fibrous connective tissues, hyaline cartilage, and or fibrocartilage, and possess a joint cavity. All synovial joints are diarthrotic. Synovial joints are quite complex in their structure, and we'll talk more about the complexities of those in a moment, and are the most numerous type of joint in the body, and also permit the greatest range of motion. And because of this, like I said, we'll discuss synovial joints in detail further on. They can also be classified by their functional classifications and based on the range of motion allowed. You can have synarthrosis, which is no movement is permitted, and at a synarthrotic joint, the bony edges are quite close together and may even interlock. And these are extremely strong joints and are located where movement between bones must be prevented. You can have amphiarthrosis, which only slight movement is permitted, and an amphiarthrotic joint permits more movement than a synarthrotic joint, but is much stronger than a freely movable joint. You can also have diarthrosis, which is a freely movable joint. Diarthrotic joints provide a range of motion that is typical of the joints in our appendages. Synarthrotic and amphiarthrotic joints are relatively simple in structure, with direct connections between the articulating bones, and diarthrotic joints are complex in their structure and permit the greatest range of motion. Along those motions, you can have different terms of axes. So you can have non-axial motion, in which linear movements where the bones slide, and this consists of your vertebrocostal joints, your sarcoiliac joints, and your intercarpal joints. You can have uniaxial motion, in which movement in one plane, either the finger joints, the elbow, the knee. You have biaxial motion, which is movement in two planes. You have the metacarpal phalangeal joints, the occipital condyles to the atlas, and you can have multiaxial motion, in which movement in three planes can occur, like the shoulder joint and the hip joint. Let's get more into detail into these joints. So the first type, fibrous joints, have several different functions and structures associated with them. These include sutures, in which a synarthrotic joint is located only between the bones of the skull. These edges of the bones are interlocked and bound together by the suture by a dense fibrous connective tissue. You can have synatosis, which is a synarthrotic joint created when two bones fuse together at the boundary between them disappears. In adulthood, the sutures of the skull normally transform to synoses, and this creates a secure cranial cavity around the brain. The epiphyseal plate of the long bones also ossifies to form a synostosis, called the epiphyseal line in adulthood. Normal fusion of the bones may also occur where these should not exist, and one example is the premature ossification of the cranial sutures, which limits the normal growth of the brain. Another example is the radial ulnar stenosis. You can have syndesmosis, in which bones are connected by an interosseous ligament. And are amphiarthrotic. And the most common example is the distal articulation between the tibia and the fibula, caused by the tibiofibular joint. Another example is the middle radial ulnar joint, but should not be confused with the joints formed at the proximal and distal ends of the radius and the ulna, which are both synovial joints and are diarthrotic. And lastly, you can have the gymphosis, which is a synorthotic joint that's sometimes called a peg and socket joint. And the gomphosis joint is found on the maxillae and the mandible, where the teeth are fixed securely in the sockets of the alveolar margins. The fibrous connective tissue between a tooth and its socket is a periodontal ligament. Next, we can have cartilaginous joints. And we can have synchondrosis, which is a rigid hyaline cartilage bridge that unites the bones of a synchondrosis joint. One example is the cartilaginous joint that's found between the ends of the first pair of the ribs and the mandibrium of the sternum. All the other ribs, you should know, form a synovial joint. A second example is the ephyseal plate found holding the epiphysis of a long bone to the diaphysis. Remember that this becomes a synostosis in adulthood when the cartilage is replaced with bone. Both of these examples are synorthotic joints. You can also have a symphysis, in which articulating bones are separated by a wedge or a pad of fibrocartilage. This articulation between the vertebrae, where a thick pad of fibrocartilage forms the intervertebral disc, is a common example of this symphysis. The articulation between two pubic bones, called the pubic symphysis, is another joint typical of this category. A symphysis is also considered an amphiarthrotic joint. And each vertebral joint, for example, only provides slight movement, but because the vertebral column is formed by so many vertebral joints collectively, the vertebral column demonstrates a high degree of mobility. You can also have synovial joints. And these also have several structural features that are unique to them. They have a joint cavity. And not only are synovial joints composed of fibrous connective tissues and possess cartilage, but they also possess a space between the articulating bones that's called a synovial cavity. You can have articular cartilages, and these line the surface of articulating bones that are composed of hyaline cartilage. However, these cartilages lack a perichondrium, and the matrix contains more water than that of hyaline cartilage located elsewhere in the body. The articular cartilage provides a slick, smooth surface to the bones, which reduces friction during movement. One of the unique prospects of a synovial joint is the synovial fluid. And synovial fluid is largely derived from blood and has a clear, viscous, egg-white consistency. And even in large joints such as the knee, the total quantity of synovial fluid is normally less than about 3 milliliters. There are three primary functions of the synovial fluid: lubrication, and when part of the articular cartilage is compressed during movements, some of the synovial fluid is squeezed out of the cartilage and into the space between the opposing surfaces. And in turn, this layer of fluid markedly reduces the friction between the moving surfaces. This is also called weeping lubrication. You have nutrient distribution. The synovial fluid in a joint must circulate continuously to provide nutrients and waste disposal for the chondrocytes of the articular cartilages. It circulates whenever the joint moves, and the repeated compression and expression of the articular cartilage pump synovial fluid in and out of the cartilage matrix. And lastly, shock absorption. And when a joint is subjected to compression, the synovial fluid provides a cushion against the shock. For example, when you jog, your knees are severely compressed, and the synovial fluid distributes that force evenly across the articular surfaces and outward onto the joint capsule. Go back for a moment. You also have the joint capsule, in which layers of dense fibrous connective tissue that enclose the synovial cavity to house the synovial joint. There are a few things associated with that joint capsule. Among them include fibrous capsules, which is a thick outer layer of continuous with the periosteum and around the articulating bones. And as a result, this adds strength and helps to stabilize that joint. You also have the synovial membrane, which is an inner soft tissue whose network of capillaries leak plasma from the bloodstream to produce a synovial fluid. We also have some accessory structures of a typical synovial joint. And in complex synovial joints, such as the knee, like I said, there's a variety of these accessory structures. You have ligaments that support, strengthen, and reinforce these synovial joints. A couple different types of ligaments that we have. We have intrinsic ligaments, which are also called capsular ligaments, and are parallel bundles of fibers creating thickenings within the joint capsule. You also have extrinsic ligaments, which separate from the joint capsule and may pass outside, extracapsular, or inside, intracapsular, the joint capsule. You have a bursa, which is a small fluid-filled pocket that forms a connective tissue and contains synovial fluid and is lined by a synovial membrane. Bursae often form where a tendon or a ligament rubs against another tissue. And these are located around most synovial joints. Bursae reduce friction and act as shock absorbers. You have a fat pad, in which localized masses of adipose tissue covered by a layer of synovial membrane. And these are commonly superficial to the joint capsule. Fat pads protect the articular cartilage and acts as packing material for the joint. When the bones move, the fat pad fills the space and creates a joint cavity and helps to change shape. You also have a meniscus, which is a pad of fibrous cartilage situated between opposing bones within a synovial joint. Menisci may subdivide a synovial cavity, channel the flow of synovial fluid, or allow for variations in the shape of the articular surfaces. There are several types of movements that these joints are capable of, and a joint can not be both highly mobile and very strong, and the greater range of motion at a joint, the weaker it becomes. A synarthrotic joint is the strongest type of joint, but permits no movement, where a diarthrosis, such as the shoulder, is far weaker, but permits a broader range of motion. There are a few different types of motion that we're going to discuss. Gliding, in which bones slide across the surface of another. Angular, in which the changing angle between two bones. Circumduction, which is basically a draw around or a conical shape of circular motion. And rotation, in which turning the bone around its own axis. These movements also relate to anatomical position, but I would encourage you to focus more about this on lab, as we will discuss this more there. As we discussed, a greater range of motion often results in a weaker joint. And we can have things called dislocations. So this is basically movement beyond the normal range of motion. And articulating surfaces are forced out of position, damages to the joint occurs, and pain from nerves that monitor surrounding tissue. There are actually no pain receptors in the joint, and most of that pain is occurring from compression of those nerves around that joint. There are 6 types of synovial joints. Again, we'll cover this a lot in lab, so we'll just only highlight this here. And then anatomical classes of synovial joints are based on the shape of the articulating surfaces of the bones. So you have plane joints that are also known as gliding joints, and articular surfaces are flat and only allow for a short gliding range of motion. These are non-axial. So intercarpal and intertarsal joints, the sacroiliac joint, the vertebrocostal joint, and others. You have hinge joints, which are cylindrical projections of one bone that fits through a trough-shaped surface of another bone. And these are uniaxial. Think the elbow joint, the knee joint, the ankle joint, things like that. You can have pivot joints, which are a rounded end of one bone protrudes into a sleeve or a ring composed of bone or ligaments, and these are uniaxial as well. Think the proximal radioulnar joint and the dens of access to the outlet. You can have condyloid joints. These are also known as ellipsoid joints, and these are oval articular surfaces of one bone that fits into a complementary depression in another. These are biaxial. You can have saddle joints, in which the articular surfaces have a concave area that fits in with a convex area of another. And you can have ball and socket joints, in which the spherical end of the bone articulates with a cup-like socket of another bone. One special class is the atlantoaxial joint, and the atlantoaxial joint is a pivot type of joint between the dens portion of the axis and the anterior arch of the atlas. These help to pivot. The development of joints. Joints will form during the embryonic development in conjunction with the formation and growth of the associated bones. The embryonic tissue that gives rise to all bones, cartilage, and connective tissues of the body is called the mesenchyme. There are several types of joint injuries that we'll discuss as well. You can have a sprain, which is a stretching or tearing of a ligament across the joint capsule. Dislocations, and these are also known as a luxation. When reinforcing structures cannot protect the joint from extreme stretches, the articulating surfaces may be forced out of position. The displacement may damage the articular cartilage, tear ligaments, or distort the joint capsule. And although the inside of a joint has no pain receptors, the nerves monitor the capsule, ligaments, and tendons are quite sensitive, so dislocations can be very painful. And a partial dislocation is called a subluxation. That's why usually when the bone is popped back into place, you tend to reduce the pain that's associated with it. You can have bursitis, which is inflammation of the bursa. You have tendinitis, which is inflammation of the tendon. Synovitis, which is inflammation of the synovial membrane. And we also talked about in earlier lectures osteopenia and osteoporosis, in which inadequate ossification of the bone, called osteopenia, begins around 30 to 40 years of age when osteoblast activity declines, while osteoclast activities continues to prevail at levels. And again, thereafter, women begin to lose about roughly 8% of their bone mass every decade. Men lose about 3%. And when the reduction of bone mass is sufficient to compromise normal function, the condition is called osteoporosis. In addition to that, we have arthritis, which is inflammatory or degenerative disease of the joint where synovial membranes thicken, called a pannus, and the fluid production decreases that results in friction and pain. And arthroscopic surgery may be necessary to treat the joint injuries, or artificial joints may need to be installed when a joint is damaged beyond repair. There are a few types of arthritis that we'll discuss. We have osteoarthritis, also known as degenerative arthritis or degenerative joint disease. It generally affects individuals about 60 or older. It can result from the cumulative effects of wear and tear on the joint surfaces, from genetic factors affecting collagen formation, and in the U.S. population, about 25% of men and 25% of women and 15% of men over the age of 60 show signs of this condition. You can have rheumatoid arthritis, which is an autoimmune disease, and RA can occur at any age, but is more common in middle-aged women, and they get that more often than men. Infection, genes, hormone changes also may be linked to this disease. RA usually affects the joints on both sides of the body equally. The wrists, the fingers, the knees, the feet, the ankles are the most common affected body parts, and the disease often begins slowly with only minor pain, but progressively becomes debilitating. You can also have gouty arthritis. And gout is caused by too much uric acid in the blood. And most of the time, having too much uric acid is not harmful. But many people with high levels in their blood never get gout. But when the uric acid levels in the blood are too high, the uric acid may form hard crystals in your joints. It can cause an attack of sudden burning pain, stiffness, swelling of the joint, and usually occurs in your big toe. And these attacks can happen over and over unless gout is treated. And this is much more common in men than it is in women. You can have bulging and herniated discs, in which compression of the nucleus pulposus, which may distort the annulus fibrosus or protrude through the annulus fibrosus into the vertebral canal. And lastly, we can talk about knee injuries here. This is a big one that we see in athletes, and a strong blow to the lateral side of the extended knee will cause 3 injuries. In sequence, tear of the tibial collateral ligament, damage to the medial meniscus, and rupture of the anterior cruciate ligament.